Our next speaker is Scott Anderson. He is the head athletic trainer at the University of Oklahoma. He's been there since 1996. He's currently the president of the College Athletic Trainers Society, the Big 12 Conference representative to the NCAA Concussion Safety Committee, and a member of the NCAA Concussion Advisory Group, along with being on the operating committee for the NCAA DoD Grand Alliance Care Consortium. Please join me in welcoming Mr. Scott Anderson.
Thank you. Certainly an honor to be here. I have great respect for the University of Michigan athletically and their athletic medicine and certainly the University of Michigan with the topic that we have today is becoming a leader in concussion and so pleased to share in that. Great affinity, too, for the University of Michigan. My youngest son, his first job was here. I have a Michigan man. He's since moved on, but we had an opportunity, been in football my entire career, but it wasn't until last fall that I attended a football game as a fan. We got to come here to the big house and enjoy that experience and the day and those types of things. And certainly a highlight. So great love for the University of Michigan. Again, appreciative of the opportunity to be here today. My topic obviously is SCAT5 and the clinical and sideline application of that. My partner for many years, Dr. Brock Schnabel, is our head team physician. He's an orthopedic surgeon with a spine specialty, and he was appointed just a few days after I was, and so we've worked together for a long time. He has a great understanding of concussion. In fact, he and Dr. Brolio were co-authors on a paper together, and so I told him that I'm going to the University of Michigan and I've got 30 minutes to talk on the SCAT5, and he just laughed at me. And I said, well, do you have anything to add? And he laughed at me again. And so this morning I sat down with the esteemed Paul Schmidt, and I said, I've got to talk on the SCAT. Do you have anything to add? And he said, well, there's bear SCAT, there's deer SCAT, and so not only do I have no conflicts, but this topic is this presentation is entirely mine. I got no help whatsoever. So, and I'm going to really, sideline and clinical, I'm really going to approach it from the standpoint of a practitioner. I mean, that's what I do. I'm an athletic trainer at the University of Oklahoma. Football is my primary responsibility, and realistically and truthfully, if all I had was clinical presentations, somebody walking an athlete in and saying, Scott, they have a concussion, can you manage them? I would have an enchanted life, at that point in time. So really more of a focus from the practitioner side and the sideline aspect of it. The SCAT has been around for a number of years, probably for almost a generation of people anymore. That's the only concussion management tool that you have and know. And so there have been several versions of it. We're at the SCAT5, but it is a tool for evaluating concussion, and we'll talk about that a little bit, but really there's, I think, again, primarily from a sideline standpoint and initial acute injury, there's some other things that we have to look at as well. We certainly don't want to miss concussion, but we're going to miss some concussions, but we don't want to miss the severe neurologic injury. We don't want to miss the cervical spine injuries that go with that. And again, the SCAT has been very well developed and very well studied, and it does, at this point in time, represent the best tool that we have, especially for sideline testing. I have a book, the Little Book of Doctor's Rules, and it's just a physician that has just written down pearls from his practice over the years, and I think this is the third edition of the book that he's published. But as we've heard today with concussion, there's not one single test that's going to identify concussion. And again, we wish that it were so simple, and certainly with sport-related concussion, as we all well know, there aren't any visible signs often. It's a varying presentation, as you know, we've all heard today. If you've seen one concussion, you've seen one concussion. Even in the same individual, they can prevent it in differing ways. Certainly the challenge with a sideline evaluation is the delayed onset. It can be minutes, it can be hours, it can be days. And invariably there's a clock running. There's a clock on the competition that's running. There's a clock that's running on the time that you have to evaluate. And so, we feel pressure to do that. But, that's one thing that we have to overlook. We have to get past. We can't be driven by a clock. The SCAT itself, establishes really a minimum of 10 minutes to accomplish the SCAT5. So you would have to get away from a clock and a time standpoint and just give the evaluation the time that it needs. And then our patient is pretty unique. As we're looking at an athlete on the sideline in the midst of a competition or maybe even a practice, probably unique in the standpoint that, what they earnestly want is to be returned to the self-same activity that created the injury and the trauma, and they want you to overlook the symptoms that you see and that they know exist, and knowing and understanding that they're at risk of recurrent injury, knowing and understanding that not only with recurrent injury they could become worse, they nonetheless want to return to participation. And so one of the first tenets of the SAC is recognize and remove, that any athlete with a suspected concussion should be removed from play. And that's pretty obvious and that's pretty simple, but the challenge gets to be identifying that concussion, being able to recognize so you can remove it. So was this a concussion or not? Certainly lost his helmet, lost some components of his helmet. So that was actually not a concussion. Not only was there no harm, there was no foul either. There wasn't a flag on the play, and we sent it off to the Big 12 conference, and they assured us that it was not targeting. There was no crown of the helmet contact that occurred. So constantly learning. This is a walk-on quarterback that we had. You can see the hands to his head. Yeah, in that case, there was harm and there was foul. There was targeting, and he was ejected. There were 13 minutes left in the second quarter at that point in time. We did serial evaluations on Baker. Holly Rowe reported that Baker's sitting on the bench and nobody's looking at him. But we did give him some serial evaluations. He denied everything. He subsequently said, well, it wasn't that contact, but there was some contact later on the drive. So he finished out the half, and we eventually pulled him at halftime just because he was overheard complaining of one single symptom at halftime. And so we removed him from play at that point in time, much to his chagrin. But there are decided advantages, I think, to being able to be on the sideline and see things versus in the clinic. And So we do have some opportunity to witness the event. We can see the mechanism of injury. We don't have to just depend on the athlete. Some of them are going to be good historians. Most of them probably are not. We can see some transient symptoms that occur. We can see posturing. We can see incoordination. We can see some seizure. Again, Dr. Schnabel, our head team physician, he's a spine surgeon. He scrubs in with our neurosurgeon sometimes, and he relates some of these incidences that we're seeing, and they, the neurosurgeons, our experts say, we don't see that. We see the athletes in our office, and we don't see the breadth and the depth of the symptoms that you're seeing on the field. So there is some advantage to that. We invariably know our athletes, their prior medical history, those types of things, and maybe specifically if they had some prior head injury history, that we can apply that, and then their personality characteristics as well. Again, be having a conversation with Dr. Schnabel as we evaluate a guy, and Dr. Schnabel said, well, he's obviously concussed. I said, no, Doc, that's just his personality. He is not concussed. So there's advantage to that, but there's disadvantages as well. We miss things from the sideline. This got some fair notoriety and attention one year. And we've had our Michigan moment as well, so to speak. This is 1999. We're playing Michigan State. I'm sitting at home watching on television, and this is what I see. Dr. Schnabel and Alex Brown, by the time they got out there, Eduardo was conscious and alert. They did not see what all of us on television watching saw. Eduardo was taken out of the game, and he was taken to the locker room. He had a chin laceration, and so they managed the chin laceration. They didn't have any intent to put him back in the game, but I suppose one part of our protocol, we should have faster physicians, because Eduardo went back in, went straight to the table, and checked into the game. And so it's only recently that I've been going to concussion conferences and not seeing this video put up as ways not to manage concussion. And so again, it's a challenging thing anyway. And again, one last one. See some replays. He actually has paint knocked off of his helmet here, but it's on the far sideline. You can see we're back on the other sideline. We're blocked by all of the players. So we really don't see any of this at all from the field. It did get some a routine replay, not because of concern to targeting, but whether he fumbled the ball or not. Fortunately, they made the wrong call, and he didn't fumble the ball, is what they said. So Oklahoma got retained possession. That's the most important take home out of this. And he did have a concussion, although he kept that secret for quite some time. No reported symptoms that day. All of his exams are fine. We serially examined him on the sideline and in the locker room. In the training room afterwards, we had an open date the following week, so we didn't play. And it wasn't until Thursday, the subsequent week, coming around time to play again. And he said, I need to talk to you. I had a concussion. I thought it was going to go away, but we've got a game, and it's not gone. And so challenging things to identify, and just a reminder, too. Sideline isn't always football. Certainly that's my take, and football gets a lot of attention. This is the worst brain injury we've had in my years at Oklahoma. Fortunately had a very good outcome, but also just speaks to the need for emergency action planning, that we can have severe injury, and we need to be prepared for that. So, difficult things to recognize, but try to figure out if it's occurred, and as it's occurred, the severe from the more minor things, and so SCAT lists some red flags. Blake has what's called a blank and vacant stare there. But you got to look for the red flags and serially evaluate them and keep them under observation. As we all know, and again alluded to, the symptoms can be slow to develop. They can be slow to report them. So we're looking for those things like neck pain, double vision, weakness, tingling, the increasing headache, onset of seizure convulsion, loss of consciousness, deteriorating conscious state, or lack of responsiveness, vomiting, and restless, agitated, and combated. So we've got to be aware of that list of red flag things, so that as we see them, then we can refer on and get them some more emergent medical attention that they need. The SCAT5 talks about cervical spine assessment, and we all get taught in our emergent care that in a conscious or in a semi-conscious individual, we're always suspecting a cervical spine injury. So we know and understand that in our general emergency medical care, but we can't forget that in terms of a head-injured individual as well. We've got to we've got to keep in mind that that we can have some other things going on there, and neck injury is one of those, and so bear that in mind and look at it, and a good rule is a painful stiff neck is always a fracture until proven otherwise, and so have a low threshold to take the precautions. Not a great video, but this is one of our players. We're in the red. We're the receiving team there. He's making a block. He's in control of the play and the situation there. So, everything seems fine, not much to worry about there. But as you watch him walk off of the field, a little bit of something there. Decided we need to give him some attention. And great credit again to Dr. Schnabel. That's him there on the right, stabilizing the spine. This individual was densely concussed, and a lot of confusion, cognitive deficits, those types of things, and credit Dr. Schnabel in the midst of that determined that he probably had a cervical spine injury, and he had a C5 fracture. And so, again, don't miss those things. Cervical spine injury has been reported in 7% of head injuries. That's not necessarily saying that, in 7% of our concussions we're going to find cervical spine injury. This was looking at head, neck, and facial trauma that reported to a trauma center. But again, the SCAT asks us to clarify those other injuries, and so we need to keep it in mind. The SCAT lists some observable signs and symptoms. We always like hands to the head. Baker had hands to the head, but laying motionless, balance or gait difficulties, stumbling, slow labored, disorientation, the blank or vacant look, and facial injury after head trauma, some signs that we need to look at. There was a group that looked at and came up with a list of consensus definitions on video replay, and video replay for us has become a significant tool. It was the season after that injury with Baker that we realized that if we have sideline video replay and we can see some of those things that everybody else is seeing, what a great tool and asset that would be. The NFL had been using it, and so we got an allowance from the NCAA Football Rules Committee that we could have sideline video so long as it stayed outside the team box, and it wasn't used it was used only for medical purposes. But they came up with a list pretty similar to the SCAT of lying motionless, incoordination, seizure, posturing, no protective action, floppy appearance, and the blank or vacant look. So, we're looking for some of those tells, so to speak. The Glasgow Coma scales there, it's in the necessary context of deterioration, and I can't think of any time that we've ever applied the Glasgow Coma. If we're seeing something, we're probably making some referrals anyway, but again, it's certainly a tool that you could use. The concussion symptom scale, probably, certainly on the sideline, it's one of the more applicable, useful tools, and maybe the best one that we have, according to some of the research and such. What's pictured there is the report on one of our athletes concussed, so it's pretty easy to pick out in that that level and depth of symptoms. But again, we have an opportunity to score some symptoms, count some symptoms, and follow them from one evaluation to another one, and try to see some improvement or continued reporting and those types of things. But again, we're still relying on the self-report and the honesty and forthrightness of the individual. The standardized assessment concussion, that's been a great tool for us. Way back in about 1999, Mike McCrae came to Oklahoma, guest of the Oklahoma Brain Injury Association, and he presented this, and I was intrigued. At that point in time, it wasn't in the public domain. I think I might be the only guy that's paid Mike $25 for this test. In the SCAT5, it was modified, a 10-word list in addition to the 5-word list. The concern or indication being that there was a ceiling effect there, and there were a population of athlete that the 5-word test was no challenge. And so we needed a 10-word list, something with a little bit more depth to it. And that hasn't been a huge problem for me in my population. I think I can think of one player over the history that maybe was in that category. But it certainly makes sense to have that option. And again, multiple versions of the test, so that very unlikely that we're going to have some learning effects going to take place. The Maddox test has been a great one as well, particularly in competition, a little more targeted. They're able to often have the, tell the place and the time and those types of things, but they have to go back and remember some things from the week before, maybe a little bit more difficult. Again, the neurological screen, being able to rule out, those bad things that are happening, and so the balance error scoring system really has been some, we use it, we apply it, some limited utility, particularly on the sideline, some difficulty with, one tester to another, and so probably becomes a little bit more of a benefit in the clinical than the sideline. And then in the best, it comes back to the delayed recall as well, the last step of the SAC, just so that there's at least a 5-minute period of time in there, and whether or not the athlete can remember the 5-word list or the 10-word list as they go through that. And then again, it really comes down to this in the sideline standpoint. Was there a concussion or not? And the SCAT's not diagnostic, but nevertheless, at some point in time, we've got to make a diagnosis. We've got to make a choice with that. And so you use the tools that you have there. And again, it is less than optimal, at this point in time, and so we're continually striving to work. Appreciate the Grand Alliance, the CARE Consortium, and their work that they're doing. Interesting to hear the Big Ten and the Ivy that they're coming up with maybe some more targeted concussion symptoms. And I know that Steve and his team have a paper in development that's identified maybe a subset of concussions that are a little bit more sensitive and specific to that. But again, at the end of the day, it just really comes down to our clinical judgment, and so again, we have these tools, we have these resources, but I think it is it's unquestionably the most difficult decision and judgment that I have to make, that my team has to make, is diagnosing a discussion within that. And far be it from me to argue with the University of Michigan that absolutely a highly attuned skill set is necessary. It's a complex presentation, and there is no single approach to it, but we do have some resources with that. And really, for us, at the end of the day, it's just taking care of the athlete, doing good medicine, good sports medicine, making decisions in the athlete's best interests. That's what we do all day, every day, in any given situation. And I think if we do that at the end of the day, not get caught up in the event, the competition and the time clock and all of those types of things, but just taking our time and taking care of the athlete is what it comes down to. So, thank you.